Hi, this is Bill Rappaci, Executive Director of the Lymphatic Research Foundation, and thank you very much for joining us in our symposium series. You will notice we've been doing a great deal of work in the area of education, and that's why we have focused on the symposium series. We also are very focused on advocacy, and we have been supporting the Lymphedema Treatment Act and have looked for the support of Senator Kirsten Gillibrand here in New York and also Senator Lindsey Graham in South Carolina to be sponsors of this, and we look forward to your continued support of those as well. But back to the issue at hand, today's symposium, and we are very proud to announce that today's speaker is Dr. Stanley Rockson. I will read Stan's credits, which are so extensive that I will only list an abbreviated list of it, but he is Chief of Consultative Cardiology, the Allan and Tina Neill Professor of Lymphatic Research and Medicine, Professor of Medicine and Director, Center for Lymphatic and Venous Disorders, Stanford University School of Medicine. More important to me than even all of that, LRF has many friends, but it has no friend as critical to its success as Stan. Dr. Rockson, not a day goes by that we are not reaching out to him or he to us, offering advice and support in our endeavors. Case in point, we recently established a tissue bank, which LRF has been talking about for quite some time, but finally kicked off, and Stan was there here in New York to help us establish that and help to negotiate that. So Stan is someone who, it turns out, seems to be up at 4:30 in the morning. There is no one more relentless in serving the patient community. There is no one more cutting edge in his research, and there is no one more respected by his peers. Today, Dr. Rockson will be presenting Lymphedema, Where Have We Been, and Where Are We Going? Without further ado, from New York, I turn it over to Stanford, with all due respect and thanks to Stan.
I think we may have solved our technical problems. I hope you're all now seeing my first slide. For those of you that don't know Stanford University, you're looking at the heart of the Stanford campus where I do my research and also see patients. And our topic today, of course, is lymphedema. Where have we been? Where are we going? Well, this first slide is perhaps a bit of good news because this is present day. It's not where we've been, it's not where we're going, it's where we are. And I'm happy to say that several months ago, this was a featured story in our major daily newspaper here in the Bay Area, the San Francisco Chronicle, which shed some light on the fact that lymphedema is a medical problem that needs awareness and that treatments are in fact available and that physicians need to be aware of what can be done for patients with lymphedema. Unfortunately, it hasn't always been so, and what I like to illustrate with this picture of an ostrich with its head in the sand is that this is really the way the medical community has greeted the problem of lymphedema for many decades, and many who are listening in on this broadcast will have experienced the frustration of trying to talk to a physician or another healthcare professional about the problem that he or she might be struggling with, only to meet someone who really is ready to bury head in the sand and not acknowledge the problem. We have to admit wholeheartedly that as a medical community, we've been ignorant about the lymphatics. But as Benjamin Franklin said several hundred years ago, being ignorant is not so much a shame as being unwilling to learn. I hope that we're at a point in medical history where the healthcare community is ready to learn about lymphedema and about lymphatic problems, and I believe that the LRF is well poised and prepared to help educate them as well as the patient community. Well, how did we get to this problem of ignorance? This slide will illustrate some data that I helped to generate several years ago when I was asked to give a presentation to the Association of American Medical Colleges, which governs the activities of all of the 110 medical schools in North America. And by doing a semi-formal poll of the heads of departments of these medical schools with about a 75% return rate, we learned that fully half of all trainees in American medical schools today experience any form of education related to the lymphatics that is less than 30 minutes in length during a 4-year medical education. So I think that will help you understand why it is, if you have encountered a doctor who's unknowledgeable about your lymphedema, it is because that doctor most likely spent such a little amount of time in his or her formal medical education that there is very little knowledge base with which to deal with the problem. It's paradoxical because we know that lymphedema is a very significant medical problem in the United States and throughout the world. If we look at just the problem of lymphedema related to breast cancer, we know that there are many hundreds of thousands of individuals in the U.S. alone who suffer from lymphedema of a single limb after they've been treated successfully for breast cancer. And this is only one of the many causes of lymphedema that we commonly recognize. So still today, we have the issue that lymphedema affects lots of individuals, but only a few physicians, relatively speaking, are prepared to recognize the name of the condition and, more importantly, to react to the diagnosis with an appropriate form of intervention to try to solve the problem. So with that as a backdrop, let's talk about what is known and is not currently being taught as widely as it might be. I think we need to start with the biology of the lymphatic system, and even that is pretty opaque to large numbers of healthcare providers. But it's really quite simple. Realistically, let's think about the lymphatic system as part of the circulation, which indeed it is. And all of us, I think, recognize to a large degree that the circulation, the movement of blood throughout the body, is driven by the heart as a pump, and the blood goes through arteries, across capillaries, into the veins, and back to the heart, forming a circle. However, with every passage of a unit of blood through that circle, about 1% of the volume of the fluid within the circulation leaks out through the capillaries and cannot return into the vein. And that 1% of circulating blood volume must travel as lymph through the lymphatic circulation. So you can think of the lymphatics as a kind of an access road to the major highway, but one that carries a great deal of traffic. And if that access road becomes blocked because, for example, lymph nodes are removed surgically or destroyed through radiation, then the flow of that traffic will be delayed, and the result will be an accumulation, which is what we recognize as edema or swelling. Well, it's very paradoxical to imagine that even though doctors today know so little about the lymphatics, they were actually first described almost 400 years ago. This is an anatomic drawing made by the anatomist who first recognized the lymphatics about 50 years after William Harvey recognized the blood circulation. So this anatomist dissected a dog, and when the colon was exposed, he noticed that there were what he called milky veins on the surface of the mesentery, which is the part of the body that holds the intestine in place. And we now recognize that these are the intestinal lymphatics. And this is the original anatomic drawing that Aselli published in 1621 and that is now housed in the medical library at Harvard University. Over the next several hundred years, anatomists devoted a lot of attention to describing and illustrating the distribution of lymphatics throughout the body. And we know that one of the most important parts of the body in which lymphatics are present is the skin. So you can see here a typical anatomic drawing from the mid-19th century showing the pathways that lymph will travel through the skin to eventually get back to the heart. As we begin to look beneath the surface, if you will, and think about what these structures look like at a microscopic level, you can see that those vessels that you saw on the surface of the skin, as we go up in higher and higher magnification, are actually composed of a kind of a capillary, what we call an initial lymphatic, that you see with the number 1 in panel C on this slide. And those capillaries coalesce to form larger and larger channels that eventually are big enough to house valves, and you see the valves in the segment of the vessel labeled with number 2, and the number 3 is actually on one of the valves. And this structure is surrounded by muscle cells that squeeze this channel and move the lymph back toward the heart. Now, these lymphatic capillaries, or initial lymphatics, work in a pretty miraculous way. This is actually a transmission electron micrograph of a lymphatic capillary, and what you're looking at the top of the slide, what looks like the big black lagoon, is the center of the capillary. And you'll see that the capillary is surrounded by what look like very fine parachute strings that we call, in anatomic terms, the reticular filaments. These are about 1/100th the thickness of a human hair, each one of them. But they are the structures that link the lymphatic capillary to the surrounding tissue. And every time the tissue becomes engorged with fluid, they pull these reticular filaments taut that opens the capillary and allows the fluid to flood in and be carried upstream back to the heart. So the lymphatic channels are very, very smart in their ability to pick up this extra fluid that is required to be transmitted back to the heart, and it will happen in a very efficient manner if all the structures are normal. So we know that the lymphatic system has this job of draining the lymph fluid from the spaces around cells. I also want to stress the fact that the lymphatic system equally serves our immune function, because all of this lymph fluid that is coming back from the tissues has to percolate through lymph nodes, and the lymph nodes have the job of orchestrating the immune response. So when somebody has lymphedema in that part of the body, the immune system is compromised and can be one of the reasons that individuals with lymphedema are prone to recurrent infections of the soft tissues. And finally, we know through the work of Gasparo Aselli in the 17th century and since that the job of the lymphatics in the intestines is to help us to absorb vital fatty substances from the diet into the bloodstream, where it can be incorporated into the body for its appropriate use. I do want to point out that the lymphatics are important to an individual who might be prone to or has lymphedema because of this circulatory function that we've just talked about. But I also want to be sure that all of us recognize that we're sitting on the brink of major discoveries in this century that will help us to understand that the lymphatics play a central role in almost all human disease. I've listed here just 6 categories of disease or disease treatment in which we already know that the lymphatics play a very, very important role. And as we learn more and more through research, I firmly believe that our ability to diagnose and control human disease in almost all of its manifestations will be heavily influenced by our ability to deal effectively with the lymphatic system. So, we've talked about the fact that if the lymphatics don't work, we end up with the problem of lymphedema. So let me talk a little bit more about how we actually get lymphedema. There's basically 2 mechanisms. On the top panel of this slide, you see the system as it is supposed to respond in health, which is to say the blood travels through the capillaries shown on the left-hand slide, and as we said, 1% of the fluid volume leaks out and does not come back into the circulation. That's what we call the lymphatic load. And as long as the vessels in the lymphatic tree are sufficient in number and size to carry that much volume, there will be net balance and there will be no accumulation of fluid. if we look at the bottom panel, this is the situation that occurs in somebody who has been treated for cancer, for example, where lymph nodes have been removed, lymph channels have been destroyed through surgery and radiation. And what happens here is that the lymphatic load is normal, but the lymphatic transport capacity is diminished. It is not sufficiently large to handle the load that is presented to it, and the excess accumulates. So that is one mechanism of lymphedema. That is the obstructive form of lymphedema based upon an insufficient lymphatic transport capacity. There is another form of lymphedema, and that is one in which the lymphatic transport capacity is normal, nothing has happened to it, but the lymphatic load has dramatically increased. We see this in a variety of circumstances. We see this when there is disease of the venous side of the circulation, so people that have blood clots in the veins or the obstruction of veins after a blood clot, individuals who have other abnormalities that raise the pressure within the veins, individuals who have burns or profound inflammation, all may have a tremendous increase in lymphatic load that will eventually present by physical examination and by symptoms indistinguishably from the obstructive form. But it is not because the lymphatic channels are inadequate, it is because the job of the lymphatics is too great to be done efficiently. In any form of edema, at some stage, we will see a physical finding like this. This is a graphic example of what we call pitting edema. What that means is this swollen limb, when examined, if, as in this case, I took my examining finger and put firm pressure on the surface of the skin in order to push the fluid out of the way, and I can leave an indent in the tissues. That's what we call pitting. Now, not all edema is pitting. Many doctors are misinformed and think that if it is pitting edema, it's not lymphedema. That's not correct, because lymphedema always will pass through a phase where the pitting is present. However, what is relatively unique to lymphedema is that with the passage of time, the quality of pitting diminishes or possibly goes away entirely. And that's what you see on the current photograph. Here I've attempted to do the same thing with my examining finger. I've made the skin a little bit red, but there has been no movement of fluid from the pressure. And that is because the edema is now non-pitting. It becomes non-pitting because over time in lymphedema, and uniquely in lymphedema, there are changes in the tissues, including deposition of scar tissue, deposition of proteins and other large molecules, and other structural changes that trap the fluid in such a way that it can no longer be freely moved by the examining finger. This is what we have traditionally called the irreversible phase of lymphedema. It is the part that we're most concerned to avoid, and the part in which aggressive treatment is hoped to play the greatest role. I'll be talking a little bit about my research at the end of the talk, in which we think we have found some treatment strategies, in fact, to render this phase somewhat more reversible, but more about that later. I'd like to talk about the relationship of lymphedema to cancer specifically, because in the United States that is indeed the largest category of presentation of lymphedema that we see. Now, in a lot of this, I'll be talking about breast cancer only because breast cancer is probably the most widely studied form of cancer-related lymphedema. I want to stress that there are other broad categories of cancer that behave in a very similar way. So individuals who've been treated for malignant melanoma, for Hodgkin's disease and other lymphomas, for uterine malignancies, cervical malignancy, ovarian malignancy, and others can also experience lymphedema, but many of the studies have been done in breast cancer, and I'll have the opportunity to share most of that with you today. So you'll see on this graph that within the first 3 years after being treated for breast cancer, depending on how you look at this and depending on how hard you look for it, upwards of 50% of the people who are treated will eventually say that they have had some swelling at some time. This will give you an idea of the magnitude of the problem of lymphedema because, as you all know, I think, breast cancer has reached epidemic proportions in the Western world. And if you consider that 50% of all those millions of individuals who present with breast cancer will subsequently present with some form of swelling that is a manifestation of lymphedema, you understand how big the problem it is. Saying it another way, if you follow these same patients over longer periods of time, you will find that perhaps 60% will eventually claim that they have had some swelling, or to say it another way, as it's shown on this graph, only 40% of the patients will say that they have been free of progression from mild arm lymphedema by the time one gets to the 8-year time point after the treatment has been begun. As I alluded to a moment ago, the problem of lymphedema, once it appears, is that it tends to progress to a direction of irreversibility. And that is because there are many processes within the body that become invoked once swelling occurs. Swelling is perceived by the tissues as an injury to the tissues, and through that injury that arises initially from the lymph system not working properly, there is almost immediately not only the accumulation of fluid, but also an abnormal function of the local immune responses. All of this leads to eventually a form of chronic inflammation. There may or may not be recurrent infection that provides the impetus to further inflammation, and eventually what we know occurs, as I've mentioned already, there is deposition of scar tissue, which we call in medical terms fibrosis, and there is deposition of abnormal degrees of body fat within the affected tissues, and the medical term for that is adipose. And all of these processes not only are relentless, but they also interrelate and drive one another, which is why we have to find ways to stop the process and eventually to reverse it. So, with such a big problem of lymphedema, particularly in the setting of cancer, and with edema being so common, how do we go about diagnosing it? Well, I put in this cartoon to say in a somewhat facetious way that the most important way in which lymphedema is correctly diagnosed is to have a well-educated and astute clinician who can actually recognize the problem from a good physical examination. We don't really need a lot of ancillary tests if the clinician really knows how to distinguish lymphedema from other presentations of swelling. However, there are diagnostic tests that are available, probably the most reliable of which, and one that should be fairly widely available through most communities now in the United States, is a nuclear medicine technique called lymphoscintigraphy. What we do with a lymphoscintigram is not really to look at the lymph channels directly, but to image their function. We inject a tracer amount of a nuclear material, in this case into the back of the hand on each side, and those are the big black star-shaped structures that you see that look like a little bomb exploding. That is the depot injection of the nuclear material, and we look for its rate of travel up the arm to the draining lymph nodes, which you see to the right of the picture as the dark stains up close to the top of the picture. Those are normal lymph nodes, so that side is normal. The other side is abnormal because we don't see uptake by the lymph nodes, and we also see that there is dark staining of the tissue in the path between the injection site and where the lymph nodes need to be. That is how we recognize lymphedema on a lymphoscintigram. There is a newer technique that is coming into wider and wider use, particularly in the breast surgery community, one that I advocate heavily because I think it is so accurate, so sensitive, and can help us to recognize the problem at such an early stage. And this is called bioimpedance spectroscopy, or the older term that you see on this slide, multi-frequency bioimpedance analysis. The principle is quite simple. If we put a little electrode on the skin of the affected arm and deliver a minor source of electrical current, too small to be felt, but large enough to be measured, that current will travel through the body, and current likes to travel through water. If you deliver a frequency of current that is low enough, it will not even be able to penetrate the cells and will be forced to travel through the body only through the extracellular space, which is where edema occurs. And because water is such a good conductor of electricity, the more water you have, the faster it will flow. This is the principle behind bioimpedance spectroscopy, because we can actually look at that phenomenon and recognize the very earliest stages in which excess body water is accumulating outside the cells. That is what lymphedema is. And we can actually detect lymphedema before any other physical examination or other diagnostic technique would show it. In fact, before there's any detectable edema whatsoever, which opens the path to treating this condition at its very, very earliest phases. This is what the machine looks like that does the bioimpedance technique, and you can see the little electrodes that are used to connect the machine to the patient's limbs in a very painless and effortless manner. There are some newer imaging techniques on the horizon. We now have the ability to use MRI to actually directly visualize the lymphatic channels, and here what is accomplished is that the injectable material, which normally for an MRI is placed into the vein, is placed directly into the tissues, just like we do for a lymphoscintigram. But instead of using a nuclear technique, we can actually look for the uptake of the material into the lymph channels by doing an MRI of the affected part of the body. So this is a technique that I think will have growing application in the years to come. Using MRI, we actually can see structures that have previously been pretty opaque to the diagnostician. So what you're looking at here are some normal individuals, normal volunteers, but we can actually see the major lymphatic channels on the MRI. The arrow points to the thoracic duct, and the smaller triangular arrows below show the portion of the thoracic duct below the diaphragm, which we call the cisterna chyli. So let me say a little bit about conventional treatment of lymphedema. This relates to the issues that I've just been talking about, which is the notion that the earlier we can detect lymphedema, the more likely we are to be able to arrest its progression and perhaps to reduce the manifestations. And then our job is, once having accomplished that, to maintain those benefits through the lifelong administration of maintenance techniques by the patient to keep things under control. The overall treatment approach, the one that has been most heavily utilized and proven over the last 30, 40, 50 years, is called by a variety of names, but perhaps the most common one is complex decongestive physiotherapy. It has a number of subsidiary elements. One of them is a specific massage technique that is called manual lymphatic drainage or manual lymphatic massage, and I'll talk about what that is in just a moment. We use multi-layer bandaging in the acute approach to the patient. We instruct the individual in decongestive exercises, and we have rigorous skin care to help to prevent the problem of infection. The notion is that the earlier we can treat, the less of the fibrosis and fatty deposition we'll be dealing with, none of which respond to these physical techniques. The physical techniques are only based upon moving fluid out of the tissues. So ideally, if we can recognize the patient before symptoms, and that would require bioimpedance spectroscopy, we can initiate very simple strategies early, or if the patient becomes symptomatic, the earlier we can begin this process, the better control we will have. If we don't do a good job, there are lots of long-term consequences, and we've touched on a lot of this already. Fundamentally, the long-term problem is that the tissues themselves increase in mass, in size, and in weight through a variety of mechanisms. And again, that is no longer a water accumulation problem. That's an accumulation of cells and fibrous tissue and adipose tissue. So here's an example of that. You're looking at a cross-section by MRI of the thigh of a human individual with lymphedema. The big white donut that you see at about 1 o'clock is the long bone in the thigh called the femur bone. And what I want to point your attention to is that around the edges of this, you see what looks like a thick grapefruit rind. That's actually the patient's skin, which has thickened to hundreds of times the thickness that it should be. In fact, on a normal MRI, you barely can see the skin. And here you can see it very distinctly because it is multiplied many, many fold, and this is part of the problem that the patient encounters, is the inability to reduce that thick, non-compliant outer surface to allow the limb to be more mobile and useful. This is an example of the deposition of the fatty material that I've talked about. These are cross-sections of the arms of a breast cancer survivor that died 20 years after breast cancer treatment of other causes. And her lymphedema was in the arm that you see to the right of the screen. All of that pale yellow to pinkish material that you see between the skin and the muscle is all fat. Now you'll notice she had not a fair amount of fat on the right side as well. So this was an individual that was overweight, but look at the increase in the amount of fatty deposition in the lymphedema arm. You can see that this arm became so heavy and non-usable that actually her muscle, which is the darker reddish brown material, underwent atrophy because she pretty much stopped using this arm based on its weight and its non-flexibility. Now, some of you may have heard about the newer surgical techniques introduced about 15 or 16 years ago by Dr. Håkan Brorsson in Sweden. This is one of his patients who has undergone a suction-assisted lipectomy of the affected lymphedema arm, and you can see what the patient looked like pre-surgically, with the affected arm being about 1.5 to 2 times the size of the normal arm. And the picture on the lower screen was taken close to 15 years after the initial surgery. You can see how effectively the arm has been returned to normal size. What was removed from the patient is seen in the graduated cylinder, on the left-hand panel, and all of the milky material that you see filling most of the cylinder is the fat that was removed. There's just a small amount of fluid that is the grayish-pink material at the very bottom. But going back to the standard approach to the earlier phases of lymphedema, we've already said this is complete or sometimes complex decongestive physiotherapy. You can see the therapist doing manual lymphatic massage in the left-hand panel. The technique here is very precise and very specific. What the therapist is doing is creating just enough stretch on the skin that he or she is opening the lymphatic channels to allow the influx of fluid. If you use too little pressure, the lymphatics will not open. If you use too much pressure, you will increase the blood flow to the skin, which will actually increase the accumulation of fluid. So the technique is very sophisticated, very precise, and requires a certain amount of education to do properly. I want to encourage any patient who's listening to undertake this only with a trained physiotherapist and not do any other form of massage to deal with lymphedema. The most important element of the acute management of the condition is multi-layer bandaging that you see in the middle panel. And again, this is a very precise technique that allows for the creation of a compartment in which muscular use of the limb drives fluid into the lymph channels and out of the body. This is not a mummification technique. This is not based on intense pressure, squeezing fluid out. It really is based upon augmenting the body's normal responses, much as a speaker connected to an amplifier on a stereo will allow the sound to be amplified and multiplied from its original source. That's exactly what we're doing here as an amplification procedure. And once the bandaging is in place, there are decongestive exercises that are undertaken to make that therapeutic effect happen. So that's the acute management, so-called phase 1, and that may last anywhere from 5 to 30 sessions and may go over many, many weeks, but eventually the patient will experience a decline in the size of the limb to a nadir point wherein no further reduction will occur. Maybe that will result in 90% elimination of the edema, or 70% or 30% or 20%. It varies by individual because, again, each individual will have a variable degree of those structural changes that are also contributing to the increased size of the limb. But when that plateau is reached, then the patient is discharged to self-management that will include the use of a compressive garment, continuation of skin care, continuation of exercise, and very likely continuation of self-administered manual lymphatic massage. Many of you are familiar with the existence of pneumatic compression devices on the market. These have had a very checkered up and down career, but I have done a fair amount of research in this area myself, and I'm here to tell you that these devices have a very specific role adjunctively in the care of lymphedema, both in the acute management and in the maintenance management. These devices are not designed to be standalone. They are meant to be used in conjunction with all of the other techniques we've discussed. If a pneumatic compression device, or so-called pump, is used by itself, it can do more harm than good, but when used alongside the other approaches, it can actually augment what can be accomplished from the standard decongestive physiotherapy. There are a variety of devices on the market, and their characteristics are summarized here. Simple biocompression devices that basically are non-programmable are useful for mild lymphedema and are useful when we combine them with the initial components of decongestive physiotherapy, and typically these are useful for individuals who have never used a pump before. The newer devices that are programmable have a variety of indications, including involvement of the trunk or the breast or the genitalia, where simple pumps cannot be of similar help, when the patient has a great deal of pain, or when there is recurrent or continuing infection or breakdown of the skin. Now, the goal of all of this, of course, is to render the individual functional, as free of symptoms as possible, and as able to carry on normal life as possible. These are actually the hands of the woman that was featured in that San Francisco Chronicle article that I showed you at the very beginning of the talk. She's completed her treatment and now is using her maintenance garment so that she can return to work in a clerical capacity, use keyboard, and do all of the other things in life that she would like to do. I would like to stress that our current treatments for lymphedema are successful, they are useful, they show demonstrable improvement in all of the ways in which we can assess quality of life in somebody who has this condition, but they cannot be construed as a cure, and unfortunately there still is no cure for lymphedema. So at this stage, what I'd like to do is talk about some of the horizons of research, some of which involves my research and perhaps some involving others, so that those that are listening that are concerned about lymphedema can have some idea about what the future may hold, and I think the future is indeed very bright. One of the avenues that has been very exciting in research has been our increasing understanding over the last decade of the molecular mechanisms through which the body creates and repairs normal lymphatic channels. So we now understand that on lymphatic vessels there are specific receptors that look like the little Ys that you see down at the bottom of the slide that respond to specific proteins that circulate in the blood that provide the message to the body to grow or repair the vessels. And it is our hope that by harnessing this power, by understanding how we can modulate these messages, we can actually help individuals grow new lymphatic channels when they have been damaged through disease or through the treatment of cancer. We know that, in fact, there are a variety of receptors on the surface of these lining cells of blood vessels and lymphatic channels, and a variety of mechanisms that we might be able to harness or, in fact, in some cases inhibit, as the case may be, to deal with some of the diseases we're concerned about. So in some cases, in lymphatic disease, we're concerned about overgrowth of lymphatic channels, which can also create problems, and here we might want to inhibit these processes in order to cause the excess lymphatic structures to regress. One very interesting development that's now several years old is the fact that there is a mouse model for a human lymphedema condition. That condition is called Milroy's disease. It is an inherited form of lymphedema, and in families that harbor Milroy's disease, there is a 50-50 likelihood of any offspring developing lymphedema. It's typically present at birth or within days after birth. And that problem is now recognized to be a mutation in the gene that makes the body develop these receptors on the surface of lymphatic endothelial cells. Now, there is a mouse model of this disease that looks identical to the human condition. The mice are born with lymphedema, and they have an identical mutation in the receptor gene, which means it really is the same disease. This is what human Milroy disease looks like in an adult. You can see that both legs are swollen with chronic lymphedema. And if you look at panel G, this is lymphedema in the so-called Chi mouse that has the mouse equivalent of the Milroy disease. So the upper paw is the swollen one, that's the Chi mouse, and the one that's labeled WT, it stands for wild type, which is an unaffected mouse, to show you the difference. Well, what's exciting about the Chi mouse is that when you take such a mouse and deliver an additional gene message of the normal gene, not the mutated gene, but the normal gene, to cause it to overexpress the growth factor, you can make the lymphedema in the Chi mouse go away. So this is the first glimmer of hope that we have that there might actually be gene therapy for a human lymphedema condition. Now, my research over the last decade and more has been more in the so-called acquired form of lymphedema. That is, somebody who starts out with normal body parts, and because of the presence of breast cancer treatment or other cancer treatment or trauma or infection, they acquire lymphedema in a part of the body. And that's what you see in the right-hand panel. This is a woman who has breast cancer lymphedema in the right arm. We initially started by looking at this problem in a model that I created in the rabbit ear. So what we do to the rabbit is very similar to what is done to the human patient when they're treated for breast cancer, namely taking out the lymph node and destroying the lymph channels at the base of the ear, which is a surrogate for the arm. So you can see that the left-hand ear in this picture is quite swollen compared to the right, so this rabbit has unilateral ear lymphedema. Now, on the right-hand panel, you're looking at the equivalent of a lymphoscintigram in the rabbit ear. And the structure that you see that looks kind of like a flipped state of Florida, that's the lymphedema ear. And all of that white color is lymph that has simply pooled in the ear because the lymph channels are not open. The blue part that could be the islands in the Caribbean is the other ear, which is functioning normally. On the left-hand side, you can see where we have treated the abnormal ear with a single injection of the growth factor, the same growth factor gene that was used in the Kai mouse. We used the growth factor itself and injected it into the ear, and 1 week later the lymphoscintigram has basically returned to normal. And while I don't have a picture to show you, I can also tell you that the ears became unswollen, and when we looked at them under the microscope, they looked basically normal. So this is an example of what we call therapeutic lymphangiogenesis, a treatment approach in which we stimulate the body to grow new lymphatic channels, and that is, of course, one of the hopes for treatment in the future. Well, we quickly turned from the rabbit to the mouse because the mouse has the added attribute of our being able to directly study the molecular processes in the test tube as well as looking under the microscope and by doing imaging. So we use a different model. This is based on the mouse tail. This model was originally described by Dr. Melody Swartz, who's one of the members of our scientific advisory board of the LRF. And this is a fluorescein injection into the lymphatic channels in the mouse tail to show you how pretty and robust the lymphatics are in the tail. We've modified her initial model in some ways in order to accomplish our own examination. So once again, we're creating a model to replicate the problem of the swollen lymphedema arm. In this case, it's the tail. The right-hand side shows you a swollen tail after we've done the surgery to create the lymphedema. The left-hand side is one in which we did a sham surgery in which we cut through the skin and allowed it to heal, but we did nothing to the lymphatics themselves, and you can see that the tail remains normal in size. Now, we've used this model for a number of studies, including the therapeutic lymphangiogenesis I've shown you already, but here we're exploring a different approach, and one that I'm very excited about, in which we are using an actual drug therapy to treat the inflammation of lymphedema to reverse it. And you can see that, again, after a very short period of time of treatment of the animal systemically with a drug to reduce inflammation, the tail returns very closely to normal. It's even more impressive when we look under the microscope. Here you can see what the skin of the mouse tail looks like both in the human and in the mouse, and you can see that they're really quite similar. I won't dwell on this for the moment. I want to show you, as an example, what can happen if we look at therapeutic lymphangiogenesis in the mouse tail. So here you're looking at what looks like a black river between the two red banks is the surgical channel where we have destroyed the lymphatics and where we inject the growth factor. And 3 days after injecting the growth factor, you can see that the channels that were initially surgically separated on either side have begun to rejoin by new vessels that have grown where they have been stimulated to grow by the injection of the growth factor. Well, with all of this, we became very, very interested in a number of issues that could be translated to the human disease state. One of the things that we learned in the mouse model is that when we studied the mouse carefully through molecular analysis, we could identify a relatively small number of genes that responded to the lymphedema condition in the skin. They're kind of markers of the presence of lymphedema, which gave us the notion that we could do a similar use a similar approach in human lymphedema and thereby discover so-called biomarkers. And the utility of this approach would be not to diagnose fully established lymphedema, but to have markers that would help us to identify the very earliest stages of lymphedema or perhaps even lymphedema risk. So what we did, and I've tried to illustrate this on the current slide, We took individuals who had lymphedema of a single limb, and we took a sample, a small sample of skin, a little eraser head, if you will, of skin in a simple procedure from the lymphedema arm and the normal arm. And we extracted the RNA, or the kind of molecular blueprint that genes create when they are stimulated in disease or in any condition in the body. And we did a technique called microarray analysis, or transcriptional profiling, to look for all of the genes that were more active on the lymphedema side than on the normal side. And by analyzing all of these gene patterns and pathways and going through a number of validation steps, we were able to identify a very small number of pathways and individual proteins that circulate in the blood in human lymphedema. So these are the pathways that are stimulated when lymphedema is present in comparison to the individual's normal arm. And from this work, we've actually identified 6 proteins that are sufficient, when measured in the blood, to discriminate somebody with lymphedema from somebody that's normal. We're very excited about this, and we're in the process of validating whether this biomarker approach can be actually used to detect latent disease and perhaps even the risk for lymphedema in somebody who is facing a surgery or a treatment that might invoke lymphedema. So the future, I think, is very bright as we begin to apply more and more approaches and techniques like this, but it will take many specialties, many individuals, many organizations working together to come up with the ultimate answers. We're learning a lot from genetics about some of the disease states that can present as genetic forms of lymphedema, but these are snapshots into the basic processes that might be manipulated even in the non-genetic forms of lymphedema. I want to talk to you about some of the forces on the horizon that might be important to you as individuals who have or are concerned about lymphedema and other lymphatic diseases. I was very privileged to serve as the chair in 2007 of a working group convened by the National Institutes of Health, which is the national organization that dispenses the biggest part of the budget devoted to research in the United States for biomedicine. And the working group was convened in order to help the NIH understand what it needed to do to move the lymphatic field forward. And this is the list of recommendations that our working group came up with after a 2-day meeting for deliberation. This is published on the NIH website, and I believe this is a blueprint for the NIH to develop new initiatives in order to make our field blossom and grow. Of course, the Lymphatic Research Foundation is at the core of the hope for tomorrow, in my opinion, and it is through the efforts of the Lymphatic Research Foundation that so much has been accomplished in the last 15 years. I specifically want to draw your attention to one of the projects of the LRF that I have had the privilege to organize and head, and that is its creation of a universal registry for lymphatic diseases that is linked to a tissue bank or biorepository that will be an extraordinarily important resource for researchers today and tomorrow. As you all understand, and based on my comments at the beginning of the talk, any given doctor who sees patients with lymphedema may see only a handful at best. We need to aggregate patients together into large numbers so that we can learn about them and learn about the problems associated with these diseases. If you have not already registered for this program, you will be able to find a link on the LRF website. I strongly encourage you to do this. It will probably take 45 minutes of your time at the most. It is a complete online process, and it is your best personal opportunity to help yourself and help all of the people in the United States and around the world with lymphatic diseases to come up with better answers. This project is a tripartite one in which we have a partnership among the Lymphatic Research Foundation, my institution, Stanford School of Medicine, that is overseeing the project with me as a principal investigator, and the Feinstein Institute on Long Island, that is the seat of the server for the registry, or the electronic part of it, as well as the biorepository. For anybody who decides to enroll in this registry, the consenting is accomplished online with a screen that will look to you something like this. And from there you will have a portal of entry into the registry to answer a series of questions about yourself in a highly protected environment that is de-identified, but that will provide very useful data for scientists moving forward. I want to let all of you know that under the auspices of the Lymphatic Research Foundation, we now have a decade-old peer-reviewed journal that has become the journal of reference for lymphatic disease. I'm privileged to serve as the editor-in-chief of this journal, and I'm also privileged to tell you that we have received an impact factor, which is a way of gauging the importance of a journal that is really spectacularly impressive, and one that tells us that our journal is being read and referenced and is a forum for research as it develops today and tomorrow. Another initiative of LRF has been the creation of a biennial research conference under the auspices of the Gordon Research Conference Series. This is probably the most prestigious biomedical conference series throughout the world, and it is a by invitation only meeting that is open to roughly 150 individuals, in which groundbreaking research is presented to one's colleagues, and in which new partnerships and collaborations are formed. We have our next session of this conference in Italy in March of 2014, and a very important element of the forward progress of our specialty. For those of you that are listening who might be individuals who have been treated for breast cancer and are concerned about lymphedema but perhaps don't necessarily have evidence of it yet, I do want to let you know about another registry that I'm involved with, one that is looking specifically at the problem of breast cancer lymphedema by tracking survivors of breast cancer. And if you go to the website for my program at Stanford, you will be able to find a link to this registry, which is also an online registration process. This is an element that probably is not going to be of interest to most individuals on the webcast, but I do want to let you know that I had the ability to co-publish what we think is the reference textbook for lymphedema last year. It's called Lymphedema, A Concise Compendium of Theory and Practice, published by Springer in London. It's quite an expensive book because it's quite exhaustive. It's almost 600 pages of really dense and complete overview of all of the science and practical implications related to lymphedema. For those of you that want to find the website related to my program, the easiest way to do this is to go to a Google search and type in the words Stanford Lymphatic, because our URL is way too long to give you, and that's where you will find the portal of entry, which looks like this. And if you choose to go to this website, in addition to the teaching materials present on the LRF website, you will find lots of additional teaching videos that may be of interest to you. This is the breast cancer registry brochure that, if you might have encountered it in a breast cancer surgeon's office, is the way that individuals learn about this program outside of a webcast like this. At this point, I think in the interest of time, I'm going to stop with this illustration of the problem of inflammation, which is one that I've told you we're working on quite intensively here at Stanford, because I do want to give those of you that are watching the opportunity to advance your questions while we still have some time.
Okay, Dr. Rockson, what is the first step for a patient if they think they might have lymphedema, and where can they find appropriate care?
Well, the very best approach would be if you are fortunate enough to live in an area of the country where there are clinicians who profess a specific specialty in lymphatic diseases or in lymphedema. Short of that, I believe the physician group that has become most knowledgeable about lymphedema, in fact, are the breast cancer surgeons who are beginning to avidly embrace this as a concern. And many, many breast cancer surgeons now, particularly those that practice within the setting of a comprehensive breast cancer clinic, have the ability to do bioimpedance spectroscopy and to do a thorough evaluation. Short of that, if neither of those are available to you, I think your internist or general practitioner is probably the best place to start.
What is more effective, compression garments or decongestive therapy?
I'm going to answer that question a little bit facetiously. It's a little bit like saying, what's better, a Ford or a car? The garment is actually part of the decongestive physiotherapy, so it is an effective component of it. It should never be utilized until the physiotherapy has brought the individual to the maintenance phase, unless the presentation is so early that really none of the other techniques are necessary. The garment is there to maintain the benefits that are achieved in physiotherapy and is mandatory once the physiotherapy is completed, but should not be initiated until the physiotherapy has been undertaken.
What about alternatives, acupuncture, supplements, laser therapy?
I'll take those one at a time. So the first question is acupuncture. I have heard anecdotally from several of my patients that acupuncture has helped them, and I don't have any reason to believe that it might not. But it's very important to emphasize that no formal studies have been done, to my knowledge, to actually demonstrate the efficacy. And more importantly, I would be very opposed to the placement of acupuncture needles within the zone of the body affected by the lymphedema. So if the acupuncture therapist is willing to do the treatment and place the acupuncture needles outside of the lymphedema zone, and very often it is the case that the needles are placed remote from the site of disease in acupuncture, then I think it's fine, with no results guaranteed, but I see no harm as long as that restriction is applied. Second question was about supplements. Unfortunately, there are no supplements that have been identified that are strictly useful in lymphedema. If you go to a health food store, you're likely to be told that there are a variety of things that they can sell you that are supposed to be good for lymphedema. But again, none of this has been proven, and I really would encourage individuals to save their money in that. I don't really think there are any miracle cures out there. I do want to say one thing about diet, however, and that is that while a heavy salt diet by itself will not bring on lymphedema, excess salt intake will result in edema formation throughout the body, and the part of the body that is already edematous will suffer proportionately to the rest of the body. So a high salt intake is a way to make your lymphedema worse, but there is not a threshold below which salt restriction will actually make the lymphedema better. I think it's just prudent to follow a modest salt intake and not go above it. And the last one was laser. Laser therapy has a small literature associated with it. It seems to be useful in the reduction of pain associated with lymphedema. There is some suggestion that it might actually be effective in reducing some of the changes that are called fibrosis by therapists. Not all of that is actual scar tissue, but rather cross-linking of proteins within the tissues, and laser might be useful, but the literature is quite sparse, and I cannot recommend it with extraordinary certainty. It's certainly no harm in utilizing it.
What about lymph node transplantation?
Lymph node transplantation is an approach that, despite the fact that it has been performed now for close to 10 years, I have to say it's still in its infancy, in that there has been very little prospective analysis of its efficacy. So there's a lot of promise that has surrounded the availability of this technique, but there are a lot of unanswered questions as well. What little objective observation we have suggests that the individuals who may benefit from this are probably those that have the surgery very early in the presentation of the edema, and that longer standing cases of lymphedema are less likely to be responsive. The risks of harvesting the lymph node from an alternative part of the body have not been well defined yet, and the overall success rate, at least in what has been anecdotally reported from the practitioners that provide numbers, is very modest at best. Under 50% response rate, I would say, is my best understanding of the current available data, but this is a field in development and in transition, so we have to do good, strong, objective, prospective analyses to decide exactly who should have this surgery and what the likelihood of benefit and or harm will be.
How does pregnancy affect lymphedema, specifically in a leg?
Pregnancy is a very unusual circumstance because there are three possible outcomes. One is it can leave the lymphedema unaffected. That would be the minority of cases. In some cases, because of the hormonal changes of pregnancy, the lymphedema actually gets better transiently, although it tends to revert to its prior state at the conclusion of the pregnancy and breastfeeding time. Or it can certainly get worse. And of course, that's probably the most common outcome, because edema of the limbs, even in the absence of lymphedema, is very common during the latter stages of pregnancy. So if lymphedema is already present, the chances that it will worsen during pregnancy are substantial. All that can be done if a pregnancy is desired and is carried out in the setting of lymphedema is to take very aggressive care of the lymphedema during the pregnancy to try to minimize the exacerbation and to keep it under control as best as possible.
If the limb with lymphedema doesn't pit and hasn't for many years, what are the treatment options?
Unfortunately, the classical definition of this stage of lymphedema, which is called stage 3, is that the problem is irreversible and that there are no effective treatment strategies. Of course, continued use of the garment will prevent further progression because a lymphedematous limb is still prone ultimately to more edema as time goes on. Our research, and one that we're very excited about, and it's an outgrowth of what we initially discovered in the mice, is that if one treats the inflammation that is driving this process in a very specific way, one can actually reverse this so-called irreversible phase. And we've now treated close to 100 patients overall with a strategy like this, and our results are extremely favorable. We're hoping to be able to publish our work within the next half year. The studies are still ongoing, and we're still enrolling patients in our clinical translational trials. But that may be a hope for the future, particularly if what we have observed to date holds up, and if we can show that the benefit is substantial and that the risks are minimal.
Besides VEGF-C to grow lymphatics, are there any other drug treatments or potential drug treatments available?
So nothing is available to date, nothing, including VEGF-C, including the anti-inflammatory therapy that we are investigating, because everything is still under an active stage of investigation. There are a number of growth factors that are being examined in addition to VEGF-C. There are stem cell approaches that are being investigated. We are, as I've said, actively investigating non-growth factor related drug therapy and are quite optimistic about it. But I think the availability to the patient community outside of a clinical trial is still months to years away.
Can we repair the lymph nodes?
The simple answer is no. Unfortunately, again, this is a subject I've thought about a lot, and I think there's some research that I'm involved in that is beginning to look at the possibility of tissue engineering new lymph nodes to replace those that have been eliminated through treatment, but there is no treatment that is effective at actually repairing damage that has already been created.
Is there any research being done in trying to grow lymph nodes using stem cells?
Yes, stem cell work is underway. It is still primarily or perhaps exclusively at the animal model level. And I think, as in so many diseases in human biology, the hope for stem cell approaches is quite optimistic and vast. But we're very early in our understanding of what can be accomplished through stem cell. And of course, what we don't know much about at all is the downside of treatment, and that all has to be worked out before it's going to be an effective therapeutic.
If no evidence of lymphedema, can use of compression garments be harmful, i.e. during air travel?
We generally recommend, despite the fact that no formal studies have been done, that a low grade of compression be used for individuals at risk for lymphedema during air travel. There is a theoretical risk, of course, that even a low grade of compression may be too much and that somehow some damage will be done. But I think it's a fairly widespread practice now in comprehensive breast cancer clinics, and certainly in my preventive lymphedema practice, that we recommend the use of a class 1 garment for air travel, and we think that the benefit will outweigh the risk, because we do know that air travel is one of the big provoking factors in transforming latent lymphedema into active lymphedema. So I think it's better to take a more aggressive strategy.
What about venous bypass surgery?
If you mean lymphaticovenous anastomosis, that's another one of the surgical techniques that is being advocated. There are very, very promising results that are being reported by groups in Italy primarily and in Japan, but the American experience with this is still in its infancy, and despite the very optimistic reports of benefit, the objectively published scrutinizable data is still pretty scant, and I continue to harbor the same conservative reservations about these techniques as I do about lymph node transfer until it's more firmly worked out.
Would growth factor be dangerous for someone who had breast cancers?
So that's one of the theoretical concerns. The growth factors that will help new lymphatic channels to develop to reduce lymphedema may also help resistant cancer cells in the body to recruit a lymphatic pathway for their own spread. And so we think that while ultimately growth factor treatment may be available to cancer survivors, it would probably require a cancer-free interval of several years before one would undertake it, and there would be that inherent risk. Now, I do want to point out that growth factor therapy would not transform a cure into a non-cure. But if an individual had micrometastases in the body, use of growth factors might accelerate the recurrence of the cancer from what might occur in the absence of the growth factor. So it's a fine distinction, but again, it's not going to take somebody out of the cure basket and put them in the disease basket. It's just going to accelerate that transformation, if indeed it does that. So we'd want to be pretty sure that subgroups that receive this would be at lower risk for recurrence, and that they would be disease-free over a suitably long enough period of time that we can trust that the disease is gone.
I've been taking aldactazide for 40 years to reduce the water. Should I continue this treatment?
I think if it's been working for you, there's no reason to stop. Don't rock a boat that's, going effortlessly through the water. But having said that, we think that diuretics are theoretically contraindicated in lymphedema because they don't address the underlying problem and they can have adverse effects. For somebody that's been doing it for 40 years without adverse effects and possibly with benefit, I would say keep doing what's working.
Your thoughts on liposuction?
My thoughts on liposuction. This will be my last question because I think we're coming to the end of our time here. Liposuction for the proper individual, I think, is an extraordinarily favorable surgical intervention. I have studied the procedure carefully with my friend and colleague, Dr. Borson, and have personally made 3 or 4 trips to Sweden to observe his techniques and his follow-up practices. But I do want to stress that the individuals who are candidates for this surgery are very small in number, probably under 5% of the patient population. They have to be in that class 3 of non-pitting edema, and they have to have the demonstrable ability and desire to wear compression 24 hours a day, 7 days a week, because all of that is necessary to get the surgical benefit. But somebody who falls into that category and who wants to trade off the continuous use of compression for the return of a normal-sized and functional limb, I think it is a wonderful procedure, one that we do here at Stanford once we screen patients to ensure that they are appropriate candidates. So with that, I'm going to thank everybody for your attention. One more question we have? One more question, sorry.
How can we enroll in your study, and is the medication used an oral or a topical one?
Thank you for that question. That's one I kind of like. The study that we are doing is a 4-month enrollment phase, but anybody who's interested in doing this has to recognize that we require about 5 or 6 visits to our center over that 4-month period of time. So there are some geographical limitations. We have had individuals who have flown to the Bay Area from Upper New York State, from Michigan, from Florida, from Texas, from very widely disparate areas. So some individuals have felt this is appropriate for them, but most of our candidates are within a car drive distance of Stanford. The medication is an oral medication. It is not an experimental drug. It is a drug that is currently available for use in the United States as a prescription, but it is not yet indicated for this use in lymphedema, which is why it's investigational. So those are the bare bones concepts related to the trial for anybody that would be interested in participating, and I'm envisioning that we will enroll something like 20 more patients before we're done with this study. You certainly can contact us, and the contact information would be available through my website, and I gave you the information on how to find that through Google. If you simply type in the word Stanford and the word lymphatic, you should be able to find the link to our website, and from there you can go to the research page and you should be able to find everything that you'd like to know. So now I'm going to say my official thank yous for all of you that have hung in here for an hour and 15 minutes. It's been a privilege to talk to you. Thank you for your support of LRF. It is your hope for the future, and thank you for the opportunity to give this talk to you. Bye-bye.